Hi, I'm Shanna, and I'm doing epidemiology week 3 discussion on impact of medication adherence on hospitalization risk and healthcare cost. This is by Michael Sokol and Kimberly McGowan, Robert, their names are hard to say, Robert Verbrage, and Robert Epstein. I chose this subject because working as a nurse in the medical field, especially oncology, we have a lot of patients that don't always take their medication the way that they're supposed to, and the outcome of that can be very significant. I'd like to start off with saying a quote that says, and this was said by U.S. Surgeon General C. Everett Koop. That quote is attributed to, and he says, "Drugs don't work in patients who don't take them," and it's cost our healthcare system quite a bit of money. And so many recent studies, it's kind of a new thing to be studying, have come out about that. And in the background of this particular study, um, I'd like to say that prescription drug expenditures are the fastest growing component of healthcare costs in the United States. Much of the growth is in drug spending and is the result of increased use. More drugs are prescribed for more people for more indications. And that includes things like cancer as well. We've moved from IV chemotherapy to oral chemotherapy in many aspects of many diseases. This accounts for more than 50% of the growth in drug spending, including diabetes and also high cholesterol as well. For many medical conditions, there is a strong evidence that prescription drugs provide clinical value. Based on that evidence, uh, pharmacotherapy has become an integral component of the treatment guidelines for many high prevalence diseases, including diabetes, hypertension, hypercholesterolemia, and congestive heart failure. The objective of this particular study was, do prescription drugs net economic value to those who pay for health care? Does drug treatment reduce overall healthcare costs by reducing patients' needs for expensive medical services such as hospitalization and emergency room treatment? And this was to evaluate the impact of medication adherence and on the healthcare utilization um, and cost for these four chronic conditions that are major drivers of drug spending in our society. The population of patients, the patients were participants in medical and drug benefit plans, PPOs, HMOs, private and these were employees of a large manufacturing company. They were identified by if they had continuous medical and drug benefit eligibility during the period, which was from June 97 to May of 1999, and there was a total of 137,277 patients that met this inclusion criteria, ages 0 to 64. They were excluded if they were patients 65 and over because most of their medical claims were not available for primary benefit through for their primary benefit plans because they're from Medicare. Medicare is our senior plan in the United States. They also did a separate sample selection. The separate study sample was drawn from the study population for purposes of analysis. And what the study sample was identified for each of the four conditions: diabetes, hypertension, hypercholesterolemia, and congestive heart failure. Patients were identified for a study sample if they were using medical services for the condition, if they received prescription drugs for the condition. Patients were included in some patients were included in multiple study samples if they met the inclusion criteria for more than one of the medical conditions under study, which we all know that's very common in our society. This was a retrospective cohort observation study. Um, who were continuously enrolled in medical and prescription benefit plans. Patients were identified for disease-specific analysis based on claims for outpatient emergency room or inpatient services during the first 12 months of the study. Medication adherence was measured and defined by days supply of maintenance medications for each condition. There was a lot of statistical analysis done in this. First of all, a logistic regression model to estimate the relationship between medication adherence and hospitalization risk for each target condition, adjusting for the same covariance as in the cost models. For each condition, they estimated hospitalization as a function of adherence level. Overall fit of the regression models was tested using the F-value and adjusted R-square with the cost models. And they used a Wald-Chai for the hospitalization models. Differences between adherence levels were evaluated for the two primary outcome measures, which were medical cost and hospitalization risk. The statistical significance of these differences were tested using two-tailed one-test medical cost and the CHI two-test hospitalization risk. So there's a lot of statistics going on. The outcome for the highest adherence level, which was 80 to 100%, was used as a reference for each pairwise comparison, and correlations among measures were evaluated using Pearson product moment correlation coefficients. The results were multivariate because they did try to, with the confounding issues with this, try to, predict some of those. For diabetes and hypercholesterolemia, a high level of medication adherence was associated with lower disease-related medical costs. For these conditions, producing a net reduction in overall healthcare costs. For diabetes and hypercholesterolemia and hypertension, cost offsets were observed in all course medical costs at high levels of medication adherence. For all four conditions, hospitalization and rates were significantly lower for patients with high medication adherence. They concluded in the study that for some chronic conditions, that increased drug utilization can provide a net economic return when it is driven by improved adherence with guidelines-based therapy. It's like you have to look for the overall picture and the long outcome versus a short outcome. It may be about the cost of drugs versus about the cost of hospitalization and all the factors that go in with ER visits and other medications that need to be used. And I'm not surprised about their conclusion. Through the research on this subject, I found that improved medication, and this is through lots of other studies, I found that improved medication adherence, getting people to take their medicine prescribed by them, is associated with greatly reduced total health care use and costs. Almost half of all Americans, approximately 133 million people, live with at least one chronic disease. Because ongoing use of prescription medication is a key component of treatment for chronic conditions, medication adherence, or making sure that patients take their drugs prescribed for them, is a matter of great importance to policymakers, insurance plan sponsors, physicians, and patients. Patients are happier when they're feeling good. There was some problems with some bias using the regression models and multiple covariants to control the effects of comorbidity on utilization and cost. And in most of the models, comorbidity was a significant predictor of utilization and cost. And it is possible that unmeasured aspects of comorbidity and risk could have biased reported associations between adherence and cost. Here's an example. If low adherence patients tend to be sicker, then the costs at low adherence levels would be inflated if comorbidity is not adequately controlled. However, in the study population, there was a positive correlation between adherence and comorbidity. The sicker patients tended to be more adherent to their drugs. In this case, comorbidity is not adequately controlled. It is more likely that the cost of high adherence levels will be overestimated. And to the degree that there's unmeasured comorbidity risk in this study, the models are likely to underestimate the cost reductions associated with high adherence, and we call this information bias. Some other things to consider in this study to think about is it was observational, so it is not possible to draw definite conclusions about the causal relationships among adherence, utilization, and cost. The cross-sectional nature of the design also poses some interpretive problems because it yields heterogeneity in groups under study. For example, the low adherence groups may include some patients who received short-term therapy or who started drug therapy late in the analysis period. But however, given the chronic nature of the conditions, it is likely that most patients were continuing medication users. They were already on the medicine or continuing the medicine. In cohort-based samples of patients with chronic conditions, most patients are prevalent cases. The study can provide a go of the typical benefits of medication adherence in continuing patients with chronic disease. The study was not designed to track the time course of treatment of newly diagnosed patients, so it cannot define how quickly after the start of therapy the benefits of adherence begin to accrue. Another, the selection methodology may produce a study sample that is weighted towards patients with more advanced disease or higher comorbidity because it may be exclusive. Some patients who visit their doctor infrequently. Each study sample included some patients who had more than one or more diseases under study, and including these patients makes the samples more representative. But because combinations of these conditions are common, excluding these patients would limit the external validity of the results. However, a consequence of including these patients in that four-study sample are not strictly independent. They're more intersectional. Future studies, first of all, there's a lot to be said. I want to go back a little bit because using this kind of information can shape what we do in the future in our economy. So we can, and to do this, future studies could include differences in methodological strategies that make the comparison among studies challenging and reduce the ability for true economic magnitude of the problem. It is required for us to develop a streamlined approach to classify patient adherence. An economic model that adequately depicts the current landscapes of the non-adherent problem using key economic indicators that speaks to a different type of policymakers that could help stratify costs and inform key policy and decision makers. Use of existing data could help better define cost and provide valuable input into the development of an economic framework to standardize the economic impact of medication adherence. And I would just like everybody to think about that and have a good day.